All right, let's jump right in. Today, we're tackling a huge topic for your surgical exams: gastrointestinal stromal tumors, or GISTs. And trust me, this isn't just another tumor. It's the poster child for precision medicine in surgery, and you absolutely have to know it inside and out. So here's our game plan. We're going to start with the core blueprint, the basics that apply to all GISTs. Then we'll break it down by location, because the roles are different for the stomach, the small bowel, and the rectum. And we'll finish up with a master plan for using our secret weapon drugs. Let's do this. Okay, first things first, we have to build a solid foundation. These are the concepts you need to nail down no matter where in the gut we find the GIST. So, where do these things even come from? Well, they pop up from something called the interstitial cells of Cajal. Just think of these as the gut's own little pacemakers, the cells that keep everything moving. And because they live deep inside the muscle wall, GISTs are classic submucosal tumors. That means they can bulge into the GI tract or grow outward into the belly. When you get right down to it, GIST is a genetic disease. The big player here, causing about 80% of them, is a mutation in a gene called KIT. Then you've got PDGFRA mutations causing another 10%. And that last little slice, we call those wild type, which includes rare birds like SDH-deficient GISTs. You have to know this breakdown because it literally tells us which drugs will work. Now here's where it gets really interesting for your exams. These mutations actually predict where the tumor is and how we can treat it. KIT mutations, more common in the small bowel. PDGFRA, usually in the stomach. But here's the absolute money slide takeaway. Our main drug, imatinib, works on most of them, except for the PDGFRA D842V mutation and those SDH-deficient ones. Those are famously resistant. Burn that into your brain. Let's walk through the workup. So, you see a suspicious mass on a CT or an endoscopy. What's the next best step? It's always an endoscopic ultrasound, or EUS. That lets us get a good look and, more importantly, a biopsy. Once you have that tissue, you're at a huge decision point. Do we watch it, take it out right away, or shrink it first with therapy? And if therapy is even a possibility, you must get molecular testing. No exceptions. So the path report comes back. What are we looking for? These are the money stains that seal the deal. CD117, which is just another name for KIT, is the gold standard, positive in about 95% of cases. DOG1 is even more sensitive. Then we have our specialty stains. If the SDHB stain disappears, that confirms it's an SDH-deficient GIST. And finally, if it's negative for things like Desmin and S100, we know it's not a mimic like a leiomyoma or schwannoma. So how do we know which GISTs are going to be trouble? For your exam, just remember this simple recipe. It's tumor size plus the mitotic rate, that's just how fast the cells are dividing, plus, and this is the secret ingredient, the anatomic location. A GIST in the small bowel is way, way riskier than one in the stomach, even if they're the exact same size. Location is everything. All right, time for a pop quiz. You are doing a scope for another reason and you find a tiny 1.5 centimeter submucosal bump in the stomach. What's the play? Is resection the automatic answer? I'll give you 5 seconds to think about it. Let's talk about the stomach. It's the most common spot to find a GIST, and it actually has its own special set of rules. And this is going to directly answer that last question. And the answer is, nope, you don't always have to resect. This brings us to a super important stomach-only rule. If you have a gastric GIST that's asymptomatic, under 2 centimeters, and has no scary features on EUS, like weird borders or ulcers, you can totally just watch it. But I have to say this again. This watch and wait strategy applies only to the stomach. Okay, so when we do decide to operate on a gastric GIST, what's the mission? It's pretty simple. We do a wedge or a segmental gastrectomy, and we have to get negative margins. But the number one absolute cardinal sin in the OR is tumor rupture. You spill those cells, and the prognosis gets way worse. And hey, good news, these tumors almost never go to lymph nodes, so no need for a routine lymphodetomy. Now let's talk about the timing of our wonder drug, imatinib. Neoadjuvant just means we give it before surgery. Why? To shrink down a huge tumor or one in a really awkward spot, making the operation smaller and safer. Adjuvant therapy is what we give after surgery to our high-risk patients. The goal here is to mop up any stray cancer cells and stop it from coming back. And the standard course for that is 3 years. Okay, round 2. You've got a 2.5 centimeter gastric GIST. It looks pretty tame on the EOS, low mitotic rate. Can we watch this one, or does it have to come out? You got 5 seconds. The answer to that question actually brings us to our next stop, the small bowel.
And let me tell you, the biology here is just meaner, and the rules are a lot stricter. So that 2.5 centimeter gastric gist from the last slide, it has to come out. The cutoff for watching is strictly 2 centimeters. And this brings us to the biggest rule of them all for gists outside the stomach. You should probably just tattoo this on your brain. If it's in the esophagus, small bowel, or colorectum, it gets resected. Period. Size doesn't matter. There is no watchful waiting. Now the duodenum, that is a tough neighborhood. If a gist is in a good spot, far away from all the important plumbing like the ampulla, then great. A simple local resection might be all you need. But if that tumor is tangled up with the ampulla or the head of the pancreas, you might be looking at a Whipple procedure. And nobody wants to do a Whipple if they can avoid it. And this is where neoadjuvant imatinib swoops in to save the day. By giving this drug beforehand, you can literally watch that tumor shrink away from the danger zone. This can turn an operation that was going to be a massive Whipple into a much, much simpler resection. This is a classic high-yield scenario for your boards. Okay, let's test it. You've got a 4-centimeter gist in the duodenum, and it's practically kissing the ampulla. What's the right move here? Do you rush straight to a Whipple, or is there a smarter play? Think fast. Yep, you got it. You biopsy first and strongly consider neoadjuvant therapy. That same logic is even more critical when we get to our final and maybe trickiest location, the rectum. This is where the surgical challenge is all about preserving function. Before you even think about operating on a rectal gist, there is a non-negotiable pre-flight checklist. 1, you need a pelvic MRI to see exactly where that tumor is in relation to the sphincter. 2, you need an EUS-guided biopsy to prove it's a gist and see how fast it's growing. And 3, you must get mutation testing if neoadjuvant therapy is on the table. Why do we do all this? Because the whole game here is about one thing: preserving the sphincter. A low rectal gist might require an abdominoperineal resection, an APR, which means a permanent colostomy. The entire point of using neoadjuvant imatinib in this spot is to shrink the tumor down, pull it away from the sphincter, and turn a life-changing operation into one that saves function. All right, last question, and it's a big one. You've got a low rectal gist, and it's right up against the sphincter. The mutation testing comes back with a KIT exon 11 mutation, the perfect target for imatinib. What do? Go straight to the big APR, or do you play it smart and try neoadjuvant therapy first? Of course, you play it smart. Neoadjuvant imatinib first. That is the textbook answer, a perfect indication. Okay, let's tie all these rules together into a master plan for using these amazing drugs, the tyrosine kinase inhibitors, or TKIs. So let's make this really simple. When do you use neoadjuvant imatinib, the drug you give before surgery? 3 main situations. 1, the tumor is just really hard to get out. 2, the operation required would be a really big deal, like taking out the whole stomach or a Whipple or an APR. And 3, you absolutely must know beforehand that you have a sensitive mutation. And what about adjuvant therapy, the stuff we give after surgery? Think of this as your insurance policy. We use it for patients who've had their tumor removed but are at high risk of it coming back, based on that formula of size, mitoses, and location. Small bowel and rectal gists often fall into this high-risk category, and just like before, you need a sensitive mutation, and the standard treatment is for 3 years. Okay, now for the things you absolutely, positively cannot mess up. These are the critical pitfalls. Number 1, never ever give imatinib for a PDGFRA D842V mutation. It will not work. Number 2, don't expect a great response in SDH-deficient gists. They're resistant too. And number 3, the golden rule. Never ever start neoadjuvant therapy without knowing the mutation status first. You have to know your target. And here it is, the entire explainer on one slide. This is your screenshot moment. It all starts with a suspected gist. You do the workup, and then you hit a fork in the road. Is it gastric or somewhere else? If it's gastric and it's tiny and low risk, you can watch it. If it's gastric and bigger or high risk, or if it's anywhere else like the small bowel or rectum, it's coming out, often with neoadjuvant therapy before and adjuvant therapy after if it's high risk. And that's our high-yield review of GIST management. I really hope this framework helps you absolutely crush these questions on your exams. If you want more friendly exam stories with little surgeons like me, don't forget to like and subscribe. Thanks for watching, and we'll see you on the next one.